Hi there, I'm Jamie Taylor. Welcome to Your Health Matters, brought to you by Kingman Regional Medical Center, your community-owned hospital. Every week on this program, I have a different guest, and we talk about different programs, services, information that I think will be of interest to you and your family. So I hope you'll stay tuned because we'll be back right after these messages with another exciting guest. Welcome back to Your Health Matters. My guest today is Dr. Thien No. Thank you for being on the show today, Dr. No.
Thank you for having me.
And you're the medical director for the new acute rehab department that is recently, well, it's been, what, about a year that we moved over to Wallapai Mountain campus?
Yeah.
So that's exciting. I mean, we were able to use that facility, put it to some good use. I know everybody in the community was asking, when are you going to do something with that other hospital?
Yeah.
So we are. And then we've expanded now as well. You've done such a great job of getting more patients in there. We had to add more beds.
Pretty much, yeah. Thank you. Number one is thank you for having me on the show, and hi everybody. So over the past year, I started in last July, and over a year we have expanded the unit from 12 bed to 18 bed.
That's awesome.
Mainly thanks to the effort from everybody on the team, including Sean, Butler, Renee, Andrew, Martin, and as well as Carol and all my PT/OT nursing staff, and as well as the support from all the physicians here and administrative. So I was very fortunate to work with such a very hardworking, dedicated people, as well as very supporting physician environment and administrative too.
That's great.
Yeah.
That's good. And so acute rehab, I think let's start with that because I don't know if everybody really knows who's watching the show. What is acute rehab and what does it mean?
Acute rehab mainly we aim at serving the patient. So let's say when you come into the hospital and you have a stroke, you check into the ER, you end up going to the either ICU or med-surg floor, and after that you left side hemiparesis versus dysphagia, difficulty to swallow, and disorder, difficulty to speak, and the family want to take you home. And so how can we, as a acute rehab facility, can help you to pretty much regain your maximal level of function, and then to return home to the family, or versus to assisted living facility. And I'm talking about multiple conditions, including amputation, hip fracture, traumatic brain injury, spinal cord, some of the chronic like multiple sclerosis exacerbation, or like chronic chronic hospital stay, patient in ICU for a long time, and now all their muscle are wasting, or they have a hard time getting up or moving around like they were before.
So you're able to help those patients regain strength?
So basically they're functioning. So we have PT, OT, and speech. Obviously we have RT, dietitian, many other team who support us, but the bulk of it is PT, OT, and speech. The speech will work with the patient cognition. PT would pretty much just train, and you just put, their walking ambulation, getting her in and out of bed, and OT work with how, simple things like how are you going to brush your teeth after having a stroke, how you can put on your clothes.
Those things that we kind of take for granted.
The shower, the daily things. Exactly.
And don't you have it set up almost like a little apartment too, so they learn how to make a bed? And
I'm very, very fortunate. The facility is very nice. It's brand new. I would quote unquote, I would consider like more like a high-end star hotel. And every room is private. So the patient have all the privacy, and all the family are welcome to visit, and you can see. So it's the next step to home. It's nice to see after a long day of therapy, the patient go there, and then the family come to visit, able to have dinner. We do dinner in the main room where all the patients come together, so they can talk to each other, can relate, and you see all the hip fracture kind of get together, all the stroke kind of get together. Exactly, they come to each other and they make friends. And we do have our annual event where we invite all the patients to come back. And some of them, it's like
almost like a reunion.
Exactly, like going to school and you come back, you see the same people. Some of them, like they even ask us, how so and so is doing.
Sure, well, because they spend quite a bit of time.
The tough time together. So that make them bond to each other.
It's like a support group for each other. And I know that, it's not an easy regimen that they're under. Don't they have to, is it a minimum of 3 hours of exercise a day?
So we, every day I go around and I do consult, I evaluate who have the potential to improve or benefit from us. I mean, obviously every benefit from coming to rehab, but who can have a significant functional or cognitive improvement coming to us. So the criteria is 3 hours a day, that including PT, OT speech, or PT and OT is depending on the condition.
Sure.
And they must do 5 days a week. That's the criteria.
So they get the weekend off?
Yeah, sometimes Sundays, depend on, you know, the therapist scheduling hour. I mean, they own that, I don't. So, but yeah, typically it'll be 3 hours a day, 5 days a week.
Wow. And the important thing I think for people to realize is that, number one, that we have this service, but that it really does help the patient get back functioning again.
Oh, yeah.
That for, I think often, like if, for instance, like you talked about, they've had a stroke.
Yeah.
They're not able, they might physically be stabilized, so they're feeling a little better, but they still maybe have one side that doesn't work as good, or they've lost some of their speech abilities, and they really can't go home to a regular home environment yet, because you even help them learn like how to navigate stairs, right? To practice going up and down stairs. Getting up and down by themselves. I mean, again, it's those things when we're healthy, we just take for granted. Like you said, brushing your teeth. Who thinks about how hard it can be to brush your teeth? Because hopefully we all do it twice a day.
Yeah.
Supposed to, my dentist tells me to. So those are little things that we take for granted until something happens that our body puts functioning that way. And so you're able to relearn, right? Just like
So we're trying to relearn the process. On top of the whole functional and the cognition, you have to think about is the blood pressure control. Are they on another medication to control cholesterol, or, you know, to basically quote unquote thin the blood to prevent a secondary stroke, secondary stroke prevention. On top of that, their bowel bladder will change too. So they start having incontinence, they have retention. So at the acute rehab, the nurse are well specialized. You know, I was fortunate to work with Renee Andrews. She's nurse manager. She's been doing this for almost 30 years. So she's well aware of all the patient condition situation. And then we retrain them in all those aspects and prevent pressure ulcer. On top of that, you know, any pain they have, a lot of time, you know, you have a lot of degenerative joint disease. On top of stroke, you have multiple other problems, not just so much the stroke. And so we work with all those. And, you know, some are complicated, like, you know, wound vac, major abdominal surgery, chronic ICU stay. And so, and on top of that, we do have a social Jamie, our great case manager. She stay in-house with us, and we're trying to get her to stay with us for full time. But she pretty much do the discharge planning. A lot of time you have the social situation tie in. You know,
with the environment they're going home to.
Exactly. A son and daughter live far away. Grandmother and dad stay here by themselves. Uncle can come once a week. So we're able to coordinate everybody, have a family meeting if needed be. Our therapist, the PTOT, goes to the patient house if you know, within the local distance to evaluate any safety issue. To prevent
like how many stairs they have. And
to prevent, you know, any rug or any, you know, lines on the floor that can create another injury for them. So it's a pretty comprehensive service for the patient.
That's good. Well, and I think too, it probably helps for the family to allay some of their concerns about, I mean, even for the wife, you know, the husband's had a stroke, she wants him to come home, but maybe she's not, you know, real strong herself anymore, and so she'd be afraid of, how am I going to help him? And so you incorporate the family too into the acute rehab training, right? I mean, so they're there, they see what you're doing, they learn how they're going to handle certain situations.
That's the very crucial part. A lot of time the condition of pathology can be very severe, but with great family support, they do get better, and we do train all the family member to participate and to help. Basically, this is the next step to home. Major transition.
It's like a halfway house.
Exactly, including everybody, all the family members, those who are very involved with the patient care.
Well, and you mentioned briefly at the beginning too about amputation is another major relearning for people. They've got a prosthetic or just have the amputation still and have to learn how to mobile themselves around, crutches, wheelchairs, those kinds of things,
Yeah,
right?
as you know, diabetes and peripheral vascular disease is very high in almost any community, and so you have an infection, now the whole leg turned black, so you have to get amputated, and you stay in the ICU, and after you come out, you're gonna have the muscle spasm, the bone and muscle pain, and on top of that you have the neuropathic pain or the phantom pain, even though the foot is gone. So sometimes they look at me like I'm crazy. I ask, is your foot still hurting you? They're like, can you see it was amputated? But what I meant is a lot of time the pathway in our brain have created so that we still feel the foot pain.
Like the foot's still there.
And and I try to help and work with them, and we do stump care to make sure there's no edema, there's no varicose hyperplasia. Basically it's just the swelling around the stump to make sure it's clean, nice and tight, so when it's time we can do the fitting of the prosthesis.
And then do they come back? Or, I mean, is it like 2 stages, so they're there for a while, after the amputation they go home, and then when they get fitted with the prosthesis they can come back and learn how to work that again?
If they come back, then they go through the consultation with Martin Garcia, so he's our program manager. He pretty much evaluate the patient, and the PTOT make the recommendation, and we get insurance approval. Granted, the way I was trained is we just do that by process, but if the patient does need rehab, money or no money, we take them.
Right.
If we feel we can make a significant functional improvement for them, we do take them. And I have done that, and over the past year I have taken numerous of non-paying case or access pending or whatever they call it. So for me, is anyone who need me, I can provide service, I do it.
That's awesome.
And then so they come in, it's either they can do it outpatient once the prosthesis fit them with prosthesis.
And then they could go to the outpatient.
Either outpatient here or come back inpatient if
Okay.
needed, if deem appropriate.
Right.
The evaluation.
Well, and I think another thing I want to touch on is this to me is a gift for our community, because often if someone's like been major brain trauma, like we talked about, and they've had to be life flighted to Vegas or to Phoenix for their condition, because maybe we don't have the neurosurgeon or whatever they needed here. But then in the past, of course, they would have to stay up in Vegas or Phoenix for all of their follow-up care and everything. So then the family is having to go back and forth between, which of course is very expensive, time off from work and all of that. So I believe that we then work closely like with Sunrise Hospital in Las Vegas to try to make sure our patients from Kingman come back here for their follow-up work. So, and I think it's important for families to know that they can request that.
Yeah.
The patient has a choice. I mean, I'm sure that their physician maybe in Vegas would say, oh, stay up here, but it is an inconvenience for the family to have to go back and forth, and for them to know they can choose to come back to Kingman, and they're going to get that same level, if not better, I think, quality of care here, and plus have them be closer to family and friends is a huge, I think, benefit for them. I've always said if you're sick and you're not feeling well, you don't want to be in a hotel room or with strangers. You'd like to family and friends.
I feel for the family, and I'm very straightforward. I mean, every physician have their limitations. So if I feel the patient need higher level care, or pretty much, to be blunt, if I reach my limit or I don't know what I'm doing, I will refer you to someone who know what they do. But for the most part, if I can serve you, I think like you say, a lot of patients, they stay up there and they told me, well, mom, dad staying up there, and I have to drive 2 hours every day to visit mom and dad. And versus the mom and dad can stay here, or grandpa, grandma can stay here, and it'll be a 5-minute drive because I live right down the street. And I think that it just, basically, I try to focus all my care around what's the patient's best interest. What is convenience for the patient, for their family, at the same time provide the same quality of service. So I completely agree with you. I spoke with the ER physician and a couple of team here. We do have an acute rehab service. If we can be a service to you, please don't hesitate to contact the hospital, and we'll redirect you to talk to our consult team, and we have a consult team that will take any consult for a patient to come back to our hospital.
Well, we'll talk a little bit more about that. We're going to take a quick break, and then we'll come back and we can talk about those requests next.
Great.
So stay tuned. We'll be back right after these messages.
stroke. And I have a lot of patients, amputee. They even asked to come back to speak to all the new one. Yeah, and
Welcome back to Your Health Matters. My guest today is Dr. Thien, who is our medical director for the inpatient acute rehab, and we're talking about that today. Thank you again for being on the program.
Thank you for having me.
I think it's just really important for our community to be aware of the service that we provide, and we were talking before the break how even if someone had to be life flighted to Vegas or to Phoenix, they can come back home to Kingman and have their follow-up inpatient, that rehab that we're talking about, right home, and so they're closer to family and friends, more convenient, and getting that same level of care. We talked about too that you have a team. Really, it's not just you, not just the nurses, it's a whole team that is helping these patients and their families deal with what they've gone through and what they're having to relearn. So we talked about the physical side. What about the emotional side of, having a stroke or having an amputation? That's mentally, you've got to learn how to deal with that too, right?
Exactly. So before I answer that question, I want to present. So every Tuesday and Thursday morning, we do have a whole group and team meeting. If you can imagine, it will be a very mid-sized room meeting. You have the PT, the OT, RT, respiratory therapist, dietitian, nursing.
That's a whole group.
Exactly. My nurse manager, the consult program manager, myself, we and the case manager and other staff member who come in, and we do go over the progress, the function, and how the patient's doing.
So you talk as for each
as a
patient,
whole team, individually.
How that patient is.
In the morning meeting, we update them on both the medical, functional, and the psychological aspect.
Okay.
And so to answer your question, yes, we do. We do have a case manager in-house to refer to any support group that they needed.
Okay.
And the nursing team is very compassionate. They're well aware of the patient's situation, including myself, because I was trained. So we do monitor for the patient. Anytime you have a big loss, I'm talking about just, talk about medical loss, like a limb or like a functional, like a stroke or TBI. You tend to go through the typical 5 stages, denial, anger, bargaining.
The 5 stages of grief.
Exactly.
Okay.
And then, depression, finally acceptance. And so sometimes the patients cycle through this. It depends on their personality.
Sure.
Some of my gentlemen, he flashed back to the time he was in war. Some people say, what am I going to do tomorrow? Am I going to be burdened for my family? And so that's why I see on our team, I do have different doctors come as a consultant, mainly Dr. Mahmood for medicine consult, and Dr. Jacob infectious disease, and the pulmonary team or the surgical team if needed be. And daily we have 1 or 2 doctors, at least 1 doctor see the patient daily, ask, hey, how are you doing today? Anything we can do for you today, 7 days a week.
Wow.
And the doctor's always a phone call away, and that is how my team and we structured the service line to be. So and just the patient being there, they see other patients who have a similar condition or another condition. That is one of the coping mechanisms, so they can relate, they talk, and they make friends.
Yes, with others who've been through the same thing.
Exactly.
Because that, I would think, is one of the hardest, or a hard part of it, is feeling that you're alone or you're the only one that's ever had this happen, right?
Yeah, case in point, I can tell you a lot of patients, they first came and they're like, I don't want to go out of my room, I want to eat in my room. And so it's up for the speech therapist, the nurse, and myself. We talk and pretty much trying to see if we can help the patient to come to the dining room and eat with everybody, to reintegrate themselves back into the community. So those are some of the helpful aspects on a psychologically we're doing for the patient.
Yeah, that's really good, because I'm sure that is a big concern. And then so you get them kind of out of their shell and start socializing more when they're in acute rehab. But then what about when they go home?
Well, once they go home, if needed be, then we talk to the case manager and the nurse manager regarding set them up with any support group if they need it.
Okay.
And they will follow with myself. So even though they go home, and the other point I want to make is even when they go home, let's say if they still need home health, PT, OT, or nursing aid, we still request those services to come to their house to work with them.
Okay, yeah, but we do have that service available for them.
And they do come back to me to tie up all loose ends. I'm talking about if something changed drastically when they last discharged from from the ARU, and then they come back and see me. So someone's always looking out for them instead of letting them fall through the crack. Unless they decide to cancel the appointment, then that's mean they're doing really well. They don't need me.
Hopefully, yeah. Because I think that when you get back into the real world, if you were to back to your old reality of what your life was like, and then that's maybe when it really hits you hard what you've lost, realizing that it's not going to be the same, but hopefully you've been able to provide them with the tools they need to learn to refunction again and do things, learn how to do it different, but still get it done, right?
Yeah, if something beyond me, let's say if the depression is too severe, or there's any red flag like suicidal ideation, anything like that, then I do refer them to a psychiatrist for further intervention. So there's always a next step to go to in getting them the help they needed.
Well, but I know that there have been many success stories of patients who have gone into acute rehab with, like we've talked about, with a stroke or with amputations, and they've been very depressed, but then once they learn that they can return to a normal life again, they can still function and not be a burden. Like you said, that would be a concern, to be a burden to the family, but learn that they can get the tools they need to return to a regular life again. That's got to be uplifting for them and exciting for them, and you give them that hope, which is, I think, very important. We all need that. And
they themselves, a lot of times, is very motivated, and they're willing to work hard to get to the next goal. And I have a lot of patients, amputee, they even asked to come back to speak to all of the new one. And we still young and very new, so we still have a lot of room to improve and develop as a whole unit. And just all my nurses, including myself, there's always room for improvement, and that's what we aim at. We plan to bring in more vocational therapists to watch movie, to play game with the patient on the Sunday, like movie hours, and we plan to bring in more people to do more like success story, like I went through this, and this is because even from the point you've been amputated to getting a new prosthesis is a journey. Sure. And I'm sure it's painful at times, so you have to really be tough and strong to push through it, and determined that you're going to make it work. And I know that your staff, they're like cheerleaders. Pretty much. You can myself. Do this, helping them know you can do this, keep going, keep trying. It's not unusual to walk to the patient room in the morning and see they crying. Because they look down at their legs and or whatever the condition they have, and especially stroke patients, they do get depressed. Once they start recovering, they realize the problem. How serious it is. And what is the normal time period that someone's usually in acute rehab? How long do they usually stay? It's dependent on condition, Jamie. Typically for my orthopedic, I'm talking about hip fracture or anything like that, it's just typically run anywhere from 1 to 2 weeks, depending on how fast the patient progresses. With the neuromuscular, like stroke, brain injury cases, about 2 to 3 weeks according to guideline. That seems to me pretty fast. What happened is we do everything based on the current guideline and literature, and so before we bring the patient in, we have to upload their data into the government. What they recommend. Exactly. And so they look at all the condition, they look at all the PTOT recommendation, and they pretty much print out a report, and 3 to 4 weeks, and they should be good. This is recommended. But however, that doesn't mean we have to follow that strictly. That's USC guideline. We do case by case. That means if the patient continues to improve fast, they reach all their goals. People change daily, and then so they will have early discharge. And I know sometimes for some patients that when they do really well, there's no place like home. They want to go home. And there's some patients who we still have, they can still improve a lot, and the days are up. We do push. We do ask for more permission for me to the
Stay
insurance or
longer.
Medicare to stay longer, and we have always done that. That's why the meeting on Tuesday and Thursday really help to guide that.
Awesome. Well, thank you so much, Dr. No, for being on the program today and sharing this information, because I'm sure that the audience has learned a lot from this, and that we'll give them the phone numbers so they can call if they have questions.
Please
And-
do, yeah.
And thank you again for being on the program. I hope you
Well-
learned something today, because I know I did, and we'll have another great guest on the program next week.
Thank you.